lifestyle, nutrition, exercise, botanicals, nutraceuticals, hormones. Good menopause management is knowing all of that spectrum.
Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi, welcome to the Dutch Podcast this week. I'm so glad you are here. I have a really wonderful guest with me today, Dr. Tori Hudson, and we are going to dive into so much about menopausal hormone therapy. We've had Dr. Hudson on the podcast before, and she's, of course, taught about menopausal hormone therapy and menopause for so long. And today, we're going to spend some time mostly talking about the use of testosterone in women, which is an area that's really been growing and kind of been trending online. And one thing I love about talking with Dr. Hudson, she's always the voice of reason. She's never an extremist. She doesn't follow trends. So we really get the chance to talk about what does the evidence clearly say? What does it not say? And where are the research gaps? And I think it was a really valuable conversation because not only did we talk about what do we know about the use of testosterone in women post-menopause, but also how to do it. How does she do it in her practice? Testing before, what types of dosages to use, how is it administered? We talked about all the different delivery formats. How do you follow up and retest? And we talked about all of these things. So it was a really valuable conversation. And then you want to stick through to the end of the episode because we have a lot of hot takes about menopausal hormone therapy in general, even with estrogen and progesterone. And we get into things like, is oral estrogen safe to use in women? What about women who had been through menopause in the last 10 years? Can they start therapy later or not? And we cover all of these kind of hot topic issues. So it is a lively and full episode. You're going to want to make sure you stay for the full hour. I won't keep you waiting anymore. Let's go ahead and introduce today's guest. Dr. Tori Hudson is a naturopathic physician, author, and educator with, like I said, over 4 decades of clinical experience dedicated exclusively to women's health. She's a medical director of A Woman's Time in Portland, program director for the Institute of Women's Health and Integrative Medicine, and adjunct faculty at several leading naturopathic institutions across North America. She also was a founder of Vitanica, a women's health supplement line, and the author of the Women's Encyclopedia of Natural Medicine. Her approach really weaves together conventional diagnostics and treatment, functional testing, and evidence-informed natural medicine to treat the whole woman, not just her symptoms. I think you're going to love this episode. Let's kick off. Well, Dr. Hudson, I'm so excited to have you back on the Dutch Podcast. Thanks for joining me today.
Howdy, howdy.
It's always fun to get the chance to chat in a podcast.
I know. This one has been a long time coming, it feels like.
It has been. And actually a lot's happened since we've had you on the podcast last time. But, I'm really excited to talk today about just kind of the updates in menopause hormone therapy, particularly around testosterone, which we're hearing so much discussion about on social media, and people are wanting to talk to their doctors about it. And I think it's going to be a great opportunity to get an update. But before we do that, for anyone who doesn't know who you are, tell us a little. You've been practicing naturopathic women's health for a really long time. I think the piece that I mean that with full compliments, by the way.
You were like looking really old, Dr.
No,
Hudson.
not at all. You look great.
42 years.
It's unbelievable. And I think there's not very many people who've been in practice that long providing women with menopause care. And so this whole person approach to women's health, particularly in like midlife, perimenopause, and menopause, you have been practicing this way that's now trending for decades, really, like thinking about prevention, thinking about lifestyle, and really layering on the right therapies for the right woman, including some hormones. I'd love to hear how your approach to hormone therapy has really evolved throughout your career. And of course, you were, in the world pre-WHI practicing, and then through that time change, and then now. So can you talk a little bit about how things have shifted in your practice?
Well, I mean, as you kind of inferred, there's sort of been there seems like there's sort of three eras of hormone prescribing for peri and postmenopausal women. The first era was sort of everything up until 2002, and the primary reason for prescribing was to reduce the risk of cardiovascular disease, and that was the primary indication. And of course, that wasn't all that compelling at the time to me, because I felt like natural medicine does a very excellent job at reducing the risk of cardiovascular disease. Then 2002 kind of, so it was sort of, yes, it was recommended robustly, routinely, and then 2002, kind of that world fell apart, and oh my God, we're causing harm, and therefore we shouldn't be prescribing it at all, was sort of the vibe, because it's going to cause this, that, and that. And then in the last 24 years, that has evolved into understanding more for whom is it indicated, and for whom is it cautionary, and for whom is it contraindicated. And but those people that were in the know in 2002 and really staying up with that research as it was really done, not in the media, you didn't stop prescribing hormones. And you realized that the risk of breast cancer was incredibly nil, almost nothing, and et cetera, et cetera. But still, the big populace was heart disease, not at all. And now the popular thing to do is everybody should go on it for any and all reasons, including things that are imaginary, or hopeful. But it's none of those, I would say none of those three eras have been really accurate.
Okay.
Are really the accurate story. And the menopause practitioners who were studious about menopause never did this, nor are they doing this. And the current environment is all perimenopausal women should go on it as soon as possible, and it's going to solve all kinds of problems and prevent all kinds of problems, and a real lack of nuance and a real lack of individualization, and yet again, a whole nother generation of not really paying attention to the research. And now we have the social media aspect and influencers and people who think they know more than they actually know, giving advice that people are following that is potentially harmful.
Yeah.
And that includes testosterone in the mix now. So there's just this generation of perimenopausal women are sort of pushing forward the envelope. And I think once again, we now have experimentation on women without following good science.
It's interesting. I was having this conversation earlier with a colleague, another naturopathic doctor up in Canada, that it can take a long time for like primary research to migrate its way into practice guidelines, like association-based practice guidelines. And the reason for that is that it takes time to do the research, and then small studies get published, and then larger studies are conducted to confirm. And then once there finally is enough evidence to make a recommendation more standardized, you have to pull the experts together that work with the group. Maybe it takes a year for them to gather at their next annual meeting. Then they have to agree, and then they have to write the guidelines, and they have to publish the guidelines. Like, you're looking at multiple years between the research being present to make good decisions for women, and that being put in a way that more doctors can really see that. And what you're saying right now around this history is making me think of that conversation, because with the WHI, probably the people who read the research and didn't just listen to the headline probably picked up on a lot of the deficiencies around that data immediately.
Yes.
I mean, maybe you can talk a little bit about that, because I love how you said like it almost didn't change the prescribing practices for the group of providers who was really in the know.
Yeah. I mean, I was fortunate because I was really following, you know, things closely, and I was fortunate in that I went to some of those scientific meetings at the Menopause Society, and Dr. Leon Spiroff was in a real leader. He wasn't in one of the authors of the WHI, but he was a main commenter, interpreter, speaker about, hey, here's what's this study is missing. And by the way, he was one of the people that called attention to, hey, these are 65-year-old women. That's like a whole different thing. That if you start menopausal hormone therapy later in the game. And so I think I definitely was at that first Menopause Society NAMS meeting post that paper.
Mm.
And where it was a hot topic, and Clarkson, who proposed the whole window hypothesis with the monkeys, he was presenting, and so I got immersed, sort of from the sort of first shelf, people who were, and it has really stuck with me, and it's made a big difference in my kind of understanding and following it all this time.
I'm curious
Not
about
to say
patients.
that I know everything there is to know, but
No one does.
and
Yeah.
it's a moving target too. It
Right.
definitely is, right? There's this, and then there's this, and there's this, and then there's this.
Mm-hmm.
But I think I think the flaws that's happening with testosterone is these tiny studies that are mostly retrospective and not randomized controlled trials that might show, oh, maybe it improves mood, and maybe it improves energy, and maybe, these are tiny, tiny studies. And so I think it's important to say, okay, this is actually what we really do know about
Mm-hmm.
testosterone in what population. And this is what is not enough evidence and a big fat maybe. And then this is the areas of potential harm that we're kind of ignoring. And so we could talk about all those whenever you want.
I definitely want to talk about all those. It's interesting with testosterone because I think there was a really interesting piece published by Sarah Glynn where she did basically just a survey of patients before and after testosterone, which isn't perfect, but there was so many, like I would call them quality of life related improvements that so many women consistently noted. And then you hear someone like Susan Davis, who's a big researcher in the field of testosterone, and she's very conservative with her
Right.
application of testosterone, saying that no, there's really nothing to that. And she says that pretty clearly. Hopefully, she wouldn't
Right.
feel that I'm misrepresenting her position by saying that, but that like outside of libido, there's really nothing else that testosterone is consistently helping. So anyway, it's a
Yeah.
very interesting conversation. We can talk. Let's start with testosterone then,
Okay.
because I mean, I think one thing that's really interesting is that testosterone seems to have just crept into that standard menopausal care discussion for women, despite like decades of it being used clinically.
Yeah.
Can
Yeah.
you
It's been used
share?
for a
Yeah,
very long
tell us
time.
a little more about that.
Well, I mean, testosterone has been around for off label for use in women for a long time. And its primary indication per the FDA and per the menopause societies around the world, its primary indication is for hypoactive sexual desire disorder, which is a persistent and recurrent deficiency or absence of desire for sex or fantasies about sex that is bothersome. That's the kind of thing,
Mhm.
something that we should tag on there.
I
It
love
has
that.
to
I
be
love that
bothersome
addition.
to the person. It's not
Mhm.
just that, oh, you're not having sex and you don't want to. No, it has to be bothersome.
And only in
Um,
postmenopausal women, right?
and
Premenopausal
only in
women.
postmenopausal,
That's right.
another really important point. Uh, yeah, in terms of the testosterone prescribing popularity that's happening. Um, So we know that testosterone modulates sexual behavior, and this is where the evidence it exists in a sufficient way, in sufficient numbers, with sufficient consistency to say, yes, this can work for women. What's not clear at all is the mood, the cognition, the muscle mass, the weight, the energy. And a lot of women come to my office asking for it for those reasons, especially energy. Just this morning, a 76-year-old woman, she's been on her estrogen progesterone for many a years. So, and is continuing it for various reasons, but she had stopped the testosterone. And she says, I'm feeling a little tired lately. I really want to add back that testosterone to help me. Well, I mean, there's about at least 10 different potential causes of fatigue and tiredness. Right. And then she goes on to explain her insomnia and her stress.
Yeah.
So I think we're ignoring, I think once again, there is this tendency to kind of go with this populist idea rather than, okay, why are you fatigued? And let's go through these steps and what's going on with your mood, and what's going on with your life, and what's going on with your sleep, and what's going on with your nutrition, and what's going on with your exercise, and all those things. And I'm not denying that testosterone could help some women with mood, energy, and cognition, but I don't feel like that is I'm hesitant to just, I'm not going to prescribe it without doing due diligence on those things. And all the proper steps, then okay, we could try it and see if it helps you, if you don't have those side effects. What I don't like happening is just keep cranking up the testosterone dose higher and higher, ignoring the range of physiological dosing. There's some folks out there saying, oh yeah, you can have a testosterone level twice as high as the high end of what it ought to be in a physiological age range, if that's what it takes to feel better and you're not having any side effects. That's a lot of that going on. And I would say that's one big fat experiment. And women, again, because we have no idea what long-term use of testosterone does in women. We are talking about 60% of women being overweight, obese. So metabolic issues, we have no idea what that testosterone might be doing harm-wise. We have no long-term data on the breast cancer thing. And as you've heard me say, well, I feel so much better on high doses, and so therefore let's do it. And I'm like, well, people feel better on, cocaine too. And so that's not the guide. And just the lack of overt side effects from the testosterone, to me, is not the be all to end all safety parameter. So when someone starts creeping above that upper range of total testosterone on a serum test, if they go above and beyond that with the prescription that I've given, if it's a little bit above, okay. But if they're above that, and even if they're not having testosterone, related acne, facial hair thinning, etc., I will suggest that we reduce the dose a little bit, because we don't have that long-term data for safety. Is what I
haven't seen people going like multiples above the top end of range.
You what?
I haven't seen prescribers dosing women like so far outside the range. I'm interested to hear more about that practice. I haven't seen that.
Yeah, there is one woman, what's her, Kelly? There are people talking about that and saying, oh yeah, women can have 160 serum level or 180 and it's okay. And I don't agree with that.
So how do you approach?
And there's absolutely no data for the safety of doing that.
Yeah. And I think it's important when it comes to no data. It's like you have to understand no data doesn't mean it's inherently safe. It's like if you lack data showing harm, doesn't mean it's safe. If you lack data showing safety, it doesn't mean it's harmful. It just truly means it's no one's asked the question, no one's borne it out in research, and it's based, their actions are based on a hypothesis that could later be proven right or wrong. I think I like to level set that for people because I think that it's tricky right now, particularly in women's health, because there just is lack of research, period, in so many areas.
Yeah.
And so providers are making the decisions they can to the best of their ability, but oftentimes, like you said, without clear information. So how do you approach dosing testosterone when there's no FDA approved products? I've actually heard just last week that the packets that are that you use for 10 days for women, that those have been, at least Amazon pharmacies, restricted prescribing to females of that product type.
Oh,
You
really?
have to buy the pump now, which is really interesting. I don't know if that's true or not, but I've heard a couple of providers say that. So, but how do you approach dosing when there's no FDA approved products and there's no reference range established for a target?
Yeah.
It's still kind of a moving target. So given your experience, length of time prescribing, and the fact that you read all this research, how are you working with patients who come in saying, I
Yeah.
have a, biochemically low T or low androgen profile, and I have low libido, and I want to try testosterone?
Well, let's talk about that for a second. There is no lab value of testosterone in a woman that relates to low libido. That's the first thing. So that's oh, wow. You can have low, medium, or high tests result and have low, medium, or high, or no libido. There is no relationship. That's the first problem that we have, and that's because
Curious.
women make very little testosterone. So the accuracy of these tests, even the test that you want, the liquid gas chromatography test, is still less than ideal at detecting these low amounts.
Can I add something else to this conversation too? Because desire in women is so complex. It's even more.
Well, yeah, we should start there, right?
Let's start there because I think we need to roll it back. When you talk about the role of testosterone in libido, we would be completely missing the boat if we didn't talk about the fact that from my experience clinically, your androgen levels for a woman, it's like a drop in the bucket of desire, really. There's so much more to it, like the quality of your relationship, how much safety you feel in the relationship. I mean, women, I feel like intimacy is very different for women and men. And then you also have that men tend to be more initiating physical intimacy, where women, you judge libido almost based upon their receptivity versus on the outright desire or fantasy or whatever measure you'd use for men. It's just very different.
Yeah, there's, what is it called, the biopsychosocial model of sexual function. And if I think if a practitioner is prescribing testosterone, they need to be educated. We need to be educated on what are the potential underlying causes of low libido in women. And that is step number one for sure. Because yes, there are multiple other pieces of the pie that could be the cause or part of the cause. Indeed, that is important. But let's say we've done that, and let's say we get to all these things seem to be in place. Her husband washes the dishes and takes care of the kids, so yes, she feels like having sex with him. But so we've asked all those questions. We've come to the point of maybe, and she's postmenopausal, and maybe testosterone would help her. So the first thing that I do is test her total serum testosterone level. And that is the recommendation of the Global Consensus Position Statement on the use of testosterone therapy for women, is that we should do that test. And you might say, well, why am I doing that test if it's not related to libido? Well, that we're wanting to do that test so that we don't hike women's testosterone up too high is the main reason. So the test result does not tell you, oh, yes, she will respond or not, or yes, you should use this dose or that dose. It might guide you as to, well, if she's already high normal, it will guide me to say, well, I'm not going to start at the highest end of the dosing then. And if it's very, very low, if not below the low end of normal, that might tell me, oh, I think I could start at the high end of the dosing. So it does tell me that. But so I do this total testosterone. It's the free testosterone is not necessary to do. That is not, so they tell us, a reflection of systemic testosterone effects.
That's really counter to what I would have anticipated. Because, I mean, if you have a lot or a little of sex hormone binding globulin, it's going to impact how much testosterone is available to the tissue.
Well, I could go back and find out why they recommend that, but that is what they recommended. All we need is a total testosterone with the right assay.
Which would be the LCMS.
They say that free testosterone, there is no evidence that free testosterone is the biologically active testosterone fraction.
I bet a lot of practitioner listeners probably would want to debate that. Yeah, we can keep going, but that is interesting that's the only piece of the guidelines.
I'm going with this. And also hormone testing is not cheap. And,
right.
and so I don't feel like we need to add on tests that we don't really need. So I do that test, determine the dose, and for me, the by and large, the maximum dose that I'm going to ever give is 10 milligrams a day to a female who wants to maintain femaleness for this purpose of sexual dysfunction. And I use a compounding pharmacy. It's economical. If, let's say, we're going to start at 5 milligrams a day, number one, it's going to be a cream because that's the most bioavailable form, and oral testosterone can cause some other potential problems. So it's in a cream. So if I want to deliver 5 milligrams a day, which is half the high end, then I'm going to write the prescription for 20 milligrams per gram. And she's going to take a quarter gram a day, which is 5 milligrams. And that will last her 4 months. So that $80 is going to last 4 months. That's very economical. Now, there are people using the prescriptions for men. Let's talk about the testosterone gel. So one tube lasts 1 day if we're prescribing for a man.
Right.
And it should last 10 days if we're at the high end, this 10 milligrams a day. It should last 10 days for women. So one thing that can be done is she can buy a 5cc syringe off of Amazon or wherever, and then she would take 1/2 cc a day, and one tube would last her 10 days, or a pea-size amount. What I don't like about doing this is I feel like there's too much opportunity for error, and there's too much opportunity for, oh, I think I'll just take more.
Interesting.
On my own. And I feel like when I say 1/4 gram a day on the bottle, and that's 1 click a day, there's the more tendency to be compliant. And let alone if they're saying a pea-size amount. Well, what kind of pea is it? I don't know. I have small peas and large peas in my garden. So I don't really like prescribing the male products in 1/10 the dose for women because of those reasons.
Okay. Makes sense.
Have I jumped over too many things here? Oh, and then the other thing I should say in terms of my habits, I will then retest the total testosterone in 4 to 6 weeks and have her come back in 6 to 8 weeks. And it takes 6 to 12 weeks to see a change in libido. And if there's no change at that first follow-up of 6 to 8 weeks and the testosterone is not above the upper range of physiological range, then and she's not responding and she's not having side effects, then we could go up. And then we'll repeat that drill again.
We'll be right back with more. Results start with easy collection. The Dutch test can help you identify the root cause of complex patient concerns, and you can ship Dutch test kits directly to your patients for easy at-home collection that fits into your workflow. Scan the code to learn more, or find the link in the show notes to place your order today. Welcome back to the Dutch podcast.
Is there a top end of like, if you're not getting testosterone, if your woman's not feeling better, and I guess you have it, do you use that top end with
the
labs
upper
or with
end is
dosing?
considered to be 10 milligrams a day.
Okay.
I have fudged a little bit and gone to like 12, but I watch her total testosterone in her blood, and that test has to be drawn in the morning and before she applies her dose that day. Because if she has her dose first and then goes to the lab, she might have a sky high, and that's not an accurate, read.
Yeah. It's interesting. We published a study earlier this year in Frontiers in Reproductive Health on the use of, because we hear a lot in the practice of salivary monitoring of testosterone dosages as well. And we just did a review of like what data is out there on serum, what data is out there on saliva monitoring. And what we tend to see is saliva really seems to overrepresent how much testosterone is in the body. I don't know if you've had, I'll send you the link, Tori, so you can take a look at it. But it can lead to people thinking that their exposure is really incredibly high to testosterone.
Yeah, I'm surprised people are even testing saliva for testosterone, because we've known for a long time that was not an accurate way to measure testosterone.
Yeah, but we still see it a lot in practice. I mean, we hear about it a lot because people call us asking. And so it's something that, we wanted to see, like, there is literature out here on that. Particularly interesting, there's a lot of literature on testosterone because of like trans male population. They have a lot of data on like what doses actually produce in this patient population desired side effects of masculinization and what doses consistently don't. So it's really a unique opportunity from a research perspective to have this full range of exposure to testosterone in a biological female, to see when do symptoms, what is kind of an upper limit where there is generally safety and you're not going to see hirsutism or voice changes is the big one that
It's
people are concerned
incredibly
about.
individual.
It's very individual.
It's very individual. And I've heard people say, when I raise this question of, well, when I raise the argument that I don't think we should keep cranking postmenopausal women's testosterone above this certain level, they'll say, well, it hasn't been, it's not causing breast cancer in trans people, and it's not causing this or that in trans people. I'm like, that's a whole different group of people. Generally, it's younger, number one. And I mean, I would say that's the big difference. It's younger, and there's a postmenopausal woman's benefits and risks should be seen for her, not compared to men or compared to trans or compared to reproductive age women even.
Mm-hmm. When it comes to testosterone use in menopausal women, it seems like it really was overlooked for a long time. I think because there's so much focus on like estrogen and progesterone being the quote unquote female hormones and testosterone being really reserved for men. Do you think that the way that testosterone's lagged behind other hormones, is that due to just lack of efficacy or consistent efficacy for different concerns women bring, or is it a research gap, or is it that symptoms aren't taken seriously? Like, where do you think that falls?
Like, why are we lagging behind in testosterone? Well, I don't know that it is lagging behind at the moment because it's so popular, but I understand what you're saying. Well, I think we have to start with maybe what is are there some biases happening around women shouldn't get testosterone for some cultural gender bias reason? And also, are we looking, is there a bias that femaleness is not good enough and therefore, we should be giving maleness? I don't know. I think there might be something going on in that whole world. I do think the research gap is significant. We almost had a testosterone patch in the US, and it was just like, it was like ready to come out and be FDA approved, and the WHI just like boom, kind of just put the skids on that.
It's just surprising that that hasn't been revisited.
Oh yeah, that's been a long time now, right?
Yeah.
Yeah. I mean, we should say that testosterone is approved in Australia. That's the one country for women, for menopausal women. They have a commercial product. You probably know maybe where else it might also be approved, but I know it is in Australia.
Where do you think we're going to go with testosterone use in women in the next 5 to 10 years? I mean, I can hear the concern in your voice that maybe we're going to have a pendulum swing where it's being
Yeah.
overprescribed, or maybe you'd say we're already there. But and we look at it 5 to 10 years down the line, if you had to like look inside your crystal ball, what do you
Yeah.
think we're gonna do? Where are we gonna be?
Well, I mean, hopefully they'll have addressed some of these research gaps, which that global consensus position statement has identified. And so I think there will be more research that will bring more clarity. I hope that there's some other consistent benefits. I hope it helps with cognition in particular. I hope that I think that is a troublesome phenomenon in women. So I hope it helps. I care more about those things than I do about people's sex drive. But
I know it is important to be thinking about the more,
because it's a day-to-day, impairment if they're
right.
fatigued, if they're cognitively suffering. I don't know, Jaclyn, I don't know. Do you think a testosterone commercial product for women is going to come out in the US in the next 5 to 10 years? I can't tell.
I'd be surprised if that wasn't something in development. I mean, at least there, I would say that generally what we're seeing in pharmaceutical medicine, is that you see a market demand and everyone races to fill it. So,
Right. Yeah, they want to.
and then
Yeah.
you see research that supports its use because it's sponsored research. I mean, not to be jaded here, but we've seen this happen before, right? You have a condition that arises, and then, or a market opportunity, and then you find a drug that can treat that, and then you go, then money actually gets diverted into that area to conduct research, and that research supports approval of a product through the FDA. That's, it's business. So I do think there is going to be one, and hopefully the research that is conducted is large enough that it does really truly create clarity around where testosterone may be helpful for women and may not be, and also the safety data, of course, would be borne out.
Right. About a testosterone, product for women. I feel like we can fully function right now with compounding pharmacies and okay, 1/10 the male dose with the Testin gel, but it would be, if a product did come out, it would be a sign that there is now decent research and more research to come. So that's a good thing.
Yeah, I think
we haven't talked about injectable testosterone for women.
Let's talk about injectable. And I think another piece that comes up that's really controversial is pellet therapy. And I think that's another one that there's a lot of very strong opinions on. I think some of them are warranted and some of them are not, personally, from my own experience and research. And I've never inserted a pellet, but I did go through the training in pellets because I wanted to better understand that as a therapy. But let's talk about those injectables.
Well, I think, again, we're talking about females wanting to maintain their femaleness. It's just, in terms of the pellets and the injectable, I feel like going that route is one more big experiment on women, and I'm not in favor of it. And I think and the research shows that there are supraphysiological levels that happen when you do that form of therapy. And we have no data on what's the safety of that over a period of time. So again, people say, "Oh, I feel great." Well, and I say, "Well, yeah, people feel great on cocaine too." But so I discourage it. I discourage colleagues. I answer it this way when asked, and people have businesses and practices around this very thing. But to me, it is potentially harmful and just an experiment in the wild west of menopause prescribing.
I think that's like the general conventional point of view towards pellet therapy. Do you feel that way about injected testosterone in women as well?
I do.
I think the biggest risk with those is that you can't undo the dose once it's in the body.
Right.
That's really, that bottom line
There's
is
no
the biggest risk.
flexibility. Yeah.
Was really surprised because we've been doing like a research review on particularly pellet administration in women, and there actually is more probably clinical data than you'd think on that. I think we're going to write it up because there's a lot out there, and a lot of the earlier studies on testosterone were using pellets in women. So there is actually more data than I think most people assume there is. And I'm not in defense or in promotion of, I want to be clear that I think there are legitimate concerns that if a woman's given too much, you can't take the pellets out. The risk of like side effects like infection and abscess are low, but that does happen. But the bigger worry is that if the dose is too high, you have to wait 6 months until it just naturally comes down.
I mean, and I haven't seen what you're finding, but to me, what kind of research on what kind of women? Meaning, are they postmenopausal? Are they this weight or that weight? Do they have these other health problems or those other health problems? Was it 50 people or was it, hundreds of people? Was it 2 months or was it 5 years? So there's a lot of stuff in there.
Yeah, there's not, just like all testosterone, there's not as much data as we'd like to see. So, you're totally right. I think the route of administration itself is not inherently a problem. And I think that across the board, it's just a matter of, can you change the dose if you need to? And with testosterone, you need to kind of go low and slow, because if you go too high, it can cause permanent harm. So there's a legitimate risk there. And I'd say the same for injectable testosterone. That's not as long of a time in the body, but you can get that supraphysiological, pharmacokinetics from both of those exposures where it goes quite high before it settles into a dose. And then eventually.
Do you find it odd that there's this mindset as like, oh, testosterone, estrogen, progesterone, but yet no way on birth control pills? I mean,
it's really interesting.
Like that to me is like a real disconnect that birth control pills have such a bias against them by many consumers and practitioners, but yet everybody's drinking the Kool-Aid on menopausal hormone therapy. And by the way, I prescribe, I'm a prescriber of hormones. But,
a lot.
But
and you teach us how to do it. Yeah.
But let's do our due diligence. It needs to be individualized on a regular basis. What are the benefits and what are the risks for this woman at minimum each year?
I love how provocative this conversation's gotten. This is great. Let's keep going.
Here's another thing that bothers me. Can I say one?
Grab my hands. Let me comment on the birth control piece though, because I would say yes, there are some individuals who have this bias, and maybe it's because we're using bioidentical hormones predominantly in menopausal hormone therapy. At least the providers I see with that bias tend to choose more bioidentical. However, I would also say there is a large number of predominantly like conventionally trained OB-GYNs who are using OCPs, but still tell women that menopausal hormone therapy is unsafe or too risky for them. So let's just put you on the birth control
that's
pill.
wild too. That's
Yeah, so
wild
it's
too.
like, oh no, you're too young, you're perimenopausal, so we really can't get you on MHT. Why don't we put
Yeah,
you on
that's
a
crazy.
combined oral contraceptive? And it's like, well, that's a progestin, which is way more stronger binding. The hormone dosing's way higher. How are you
Yeah,
creating
the
this in
estrogen
your
is at
brain?
least 5 times higher than what
Yes.
I'm talking about for this woman.
So I see
Yeah,
both
that's
ways.
another crazy one.
I see it both ways, and there's more. We get which one's on your mind? Because I have others too. We should just bring up and talk about these myth busts.
Well, I'm glad you brought up that other side of that of that issue of birth control pills. Well, this is pretty recent for me to really kind of grab hold of this. No one is dying of hot flashes and night sweats, and no one is dying of low libido, and no one is dying of I just wish I felt better. But women are dying of heart disease. And to me, all this noise about let's test this, that, and that, about hormonal related stuff, and well, what's their lipids? What's their apolipoprotein B? What's their lipoprotein A? What's their A1C? What's their kidney function? What is her objective and subjective risk of cardiovascular disease? I'd like to see a lot more noise come from here to over here, because that's what women are dying of.
I
It's
love
hard.
this. This has been a soapbox for you lately too, because we've talked about this. Like I think every time I've talked to you, we've talked about cardiovascular risk and
True.
postmenopausal women.
I don't like being so predictable, but
But
yeah.
it's rightfully so. I mean, I'm glad it's a soapbox for you because you're absolutely right. But it's not sexy and it's not something people think about until you have a heart attack. I mean, it's something that it's hard to, it's just kind of boring and mundane to be thinking about prevention of cardiovascular
I
disease
know heart
unless
disease
you were
has suffered from
impacted.
that for a long time.
Yeah, it's struggled. It like needs a rebrand, but it's so critically important. And I'm glad that you're bringing this up. And I wanted to ask you because a lot of the data pre-WHI that pushed for hormone therapy was around cardiovascular protection.
Yeah, it was
Is that
the
data
number.
still relevant? Is that something that we should be talking with our patients about?
Well, as you know, the prevention of cardiovascular disease is not considered an indication for prescribing menopausal hormone therapy. This is something else that sort of naturopathic, functional medicine, integrative medicine community has grabbed hold of to say, oh, you should go on hormones now to prevent heart disease. Well, the reason why it's not an approved indication, because the data is really mixed on this topic. It's not at all clear that you prescribe menopausal hormone therapy in perimenopause or early menopause, that it will reduce the risk of heart disease. And of course, if you start it later, it will actually increase the risk. So I feel like that would be something else to get great clarity on. I'd like to see clarity on can menopausal estrogen therapy starting at a certain age and in certain women reduce their risk of heart disease? And while we're at it, we got to know the answer to the whole Alzheimer's thing as well.
Yeah.
Is it a plus or a minus or a neutral? We don't know that. And for a practitioner to say, oh, I'm putting you on hormones to prevent heart disease and Alzheimer's disease, they should also say, I hope. I mean, we don't know for sure that that's true.
I think it's a really complex, these two areas, cognitive health, Alzheimer's disease, cardiovascular. I know that's three, but I'm grouping Alzheimer's and cognitive there. I think it's going to be really tough for research to clarify whether hormones are helpful or not helpful in the long term because they're so multifactorial. And I think the question really ends up being, is estrogen therapy dosed from perimenopause on enough to affect all of the other things that have driven that disease in a woman enough to make it worth being on, right? That's really the question we're asking because we know fundamentally both of those conditions are metabolic in nature and driven by so many pieces. And we know estrogen can help with healthy metabolism or help preserving it when we look at things like women who are on GLP-1s and estrogen tend to lose more weight than women who are on GLP-1s alone. Like there's evidence to suggest that, and more, that estrogen helps with metabolic health parameters, but it's almost overcoming this mountain of challenge. And is like, is the hormone enough, you know?
Well, I would also like to add to the conversation again that there's a lot of noise around hormones, when actually what we do know is that drinking low to no alcohol reduces your risk of Alzheimer's.
Mm-hmm.
Exercising X amount of time a week reduces your risk of Alzheimer's. Eating a Mediterranean diet reduces your risk of Alzheimer's.
I think about Joe Pizzorno's work too on toxin exposure and connections to cardiovascular disease. There's so many other really big drivers.
Yeah, so why do you think there's this hyper focus in peri and postmenopausal women right now around that all your problems are hormones and the solution is hormones?
Well, I think there's an appropriateness to looking at the role of hormones, because we do know that with the
I'm not saying that's not appropriate, but I'm just saying this hyper focus of
it's a medication.
Women is their hormones, and the solution for women is their hormones. I think I don't understand. I don't feel like that is the direction that we should be emphasizing.
Yeah. I think I view it as a yes and, because I completely agree. We're missing the boat if the only thing we talk about and focus on is hormones. I mean, we're naturopathic doctors, so we trained in this. Like the reason why I chose this path is because I want to be focusing on all the lifestyle factors that preserve health long term. And there's an additional risk after the cessation of ovarian function with menopause. We know that there's a steep change in risk factors around that time, like 12 months before the last period to the couple of years after. There's a huge change in bone health. There's a huge change in heart health. Like there is a very steep cliff, so in that, when we look at that, I think it is appropriate for us to be looking at hormone therapy as a way to reduce the exposure to that cliff, make it less steep, slow it down, eliminate it. We're not really sure what that's going to look like yet. And I think when we're looking at women who are in that age bracket, they've already lived a life. You can't undo anything that's been done. So what can we do now is always the question. And hopefully providers are taking that holistic approach to really focus on proper screening, like you talked about, all the lifestyle factors, and then using hormones as one more tool in the toolkit, but not the only tool. Do you disagree? Push back.
No. I don't. I'm just thinking while you're talking. I wish that providers, and especially providers in our community, were thinking more judiciously and individualizing and not just, everybody, no matter what age, no matter what the circumstances, you should go on these hormones, and you should go on these supraphysiological doses of hormones. I feel like there's that habit and practice and vibe is out there, and I feel like it's odd to me that the alternative medicine community is the ones that are doing that, because we're historically kind of more hesitant,
like like slow down on the drug prescriptions. Yeah, I see what you're saying.
But I feel like in the era of sort of biohacking, it seems like it's kind of winning the race.
Yeah, I mean, it's interesting because I think you talk about this as you could almost see the push and pull between I'm going to use the extreme examples, right? Well, you have like the aging gracefully, don't do any intervention, support women through the menopausal transition from a comfort perspective, but don't use hormones, which actually is really what I was trained on, to be honest, because I was in med school during the time of WHI. Like I was there from 2003 to 2007. So I took my gyne class like right at the height of everyone talking about lowest dose, shortest duration possible. So I think the strength in that is I learned all
Yeah.
of the other things, and
Yeah.
that I don't feel like I learned hormone prescribing really at all in school. I've learned that since then.
Yeah.
Because in my practice, I used it so minimally. It was my last resort for women who weren't better on all the other therapeutics and lifestyle changes. So the nice thing about that is I feel very well prepared to help women who don't want to be on hormones, or to make sure we have a comprehensive plan put together. But I think my paradigm's really shifted now, where women are living a lot longer and we know more about the ovary and we know more about the epigenetic changes that happen around menopause, and we know about a lot of these other risks and the timing of those risks, that I do think it's like a wellness lever that a lot of women appropriately are looking at. But right. I mean, it's not for everybody, and it doesn't have to be. If a woman is saying, I really don't want to be on hormones, who are we to be selling her on them? I think it's, you share what they can do and what they can't do, and who they're good for and who they're risky for. And,
I mean, I also wanted to say, I have other conversations with other populations of women where they're afraid to go on hormones, and I want them to go on. Like they have they have POI since they were 25, and
Right.
in like, and so there's those conversations, like because you haven't been on hormones, you are at higher risk for, X, Y, and Z. So, the beauty of naturopathic medicine for me is, and you've heard me talk about this, just like to know the spectrum of options, lifestyle, nutrition, exercise, botanicals, nutraceuticals, hormones, and over-the-counter medications, other prescription non-hormonal medications. To me, the good menopause management is knowing all of that spectrum and the benefits, the ups and the downsides of all it. When is this under treatment? When is this over treatment? When is this just the right treatment? And it evolves and changes. It's not static, because she's aging.
Definitely. Well, I have two more things I want to make sure we talk about today before we wrap our time together. The first should be pretty quick, but I think this is another bias I see, particularly in the naturopathic community, which is anti-oral estrogen. Like, oral estrogen is unsafe.
Oh, good. I'm glad you brought that one up.
Yeah, and this is something that I was also trained on, like, oh God, I would never give anyone oral estrogen, no way. But then when I actually did the research myself, the way that I word it is transdermal is safer, but oral is safe. And I think, can you speak to that a little bit? Because you are such a respected voice here. There's not a lot of people who've spent more time in the literature. And I do think that for some women, transdermal is a pain in the butt. They don't want to put a patch on. They don't want to put a gel or a cream on. And they'll pop their pills with everything else. Can you just share your perspective on that?
Oral is cheap and easy. And it's been maligned. And again, something has happened where it's got to be a patch. I wouldn't even necessarily say across the transdermal is not inherently safer than oral, except, in terms of DVTs and strokes. Those are the big areas. There's a few other people that should be on transdermal: migraines with auras, elevated triglycerides, a few others, but the DVT and the stroke is the biggie. And even that, to say it's a biggie, that risk is tiny in most people.
Right.
So unless, I would ask practitioners to review what are the contraindications to oral, what are the cautions to oral, and don't automatically deprive women of oral estrogen. Like you said, the patch, a lot of women don't like that. It falls off, it leaves a mark, doesn't, they get the contact dermatitis, the gel is messy. Yeah, I probably prescribe far more oral than most people that you and I know, because it's easy and it's cheap. And at compounding pharmacy, now I can put some this or dose of progesterone in there.
Yeah,
if
you
I
can be all
want.
in one. All right, I guess I have two more things still because I thought of another one. We haven't talked today about vaginal estrogen, and I do
Oh,
feel like this is such an important, like, PSA for people to know about. And the more data I read, it's like, okay, we used to use it for GSM and postmenopausal women, this genitourinary syndrome of menopause. But now I think it, like, even using it in perimenopausal women, but even women of reproductive age who have recurrent UTIs, this is something that I think is life-saving medicine and so easy. So can you just share a little bit about vaginal estrogen, why
well,
we
I don't
should
know
be
about
thinking about it?
life-saving, but I
Well,
do
it is
think
when you
that
think about
estrogen
like,
is a magic medicine. It's a magic medicine. And uh and if someone already has GSM, which isn't just itchy or burny or or dry, it's recurring UTIs, like you said.
mm,
It's urinary incontinence. It's prolapse of the urethra, the bladder, the uterus. Uh, it's significant impact on prevention, on treatment and prevention. Um, and older women, yes, who get UTIs, that can go downhill pretty fast.
that's what I was
Uh,
thinking about because
yeah,
you end up getting like pyelonephritis,
yeah,
sepsis, and you end up in
yeah,
nursing homes. It's a huge burden. And actually,
yeah,
like, and when I say life-saving, I mean because that oftentimes
yeah,
progresses. It's
yeah.
like the time people roll downhill, and unfortunately, it's
I
a big
don't,
death.
you might have the numbers, but the a number of women that have GSM and then are prescribed estrogen vaginally or who take it's like the discrepancy is huge. These are the women that need it. These are the amount of women that are getting it and using it. It's
Mhm.
huge. And so everything that we've said so far about benefits and risks of estrogen has nothing to do with this.
Mhm.
Vulvovaginal estrogen in the low doses in the prescribed methods, it is it's a game changer for quality of life, and it's in the moment, and it's a game changer in prevention as well. And yes, we need to be doing a lot more of it.
The last one, and I really would love your perspective on this uniquely because I think you probably have a huge group of women in this category in your practice, having been in practice so long and seen women for literally decades of their lives. We have a group of women who really went through the healthcare system during WHI and they were told not to go on hormones and they went through menopause and time's gone by and now we see these benefits. I'm getting asked this all the time. I'm 10 years out, I'm 12 years out. Should I think about going on hormones? Is it absolutely contraindicated? What are you telling these patients? And how are you thinking about this, knowing that there is an increased risk when there's a gap in hormone exposure from menopause and
Yeah.
giving hormones, but there's also benefits that can be obtained for some women potentially. How are you handling this and how are you talking about this with women who feel like they've missed the boat?
Well, I would emphasize it's individual. What is the benefit and what is the risk? And if she's post 60 or post 10 years menopause, I really want the nuances of her risks. And for me, the one I'm most concerned about is initiating that later in the game, increasing her risk of cardiovascular disease and possibly Alzheimer's. But the ones that I can really do something about is what is her risk. The one that I can really properly assess is cardiovascular. So I'm going to do the prevent calculation and get the data points I need for that. I'm going to add apolipoprotein B and a lipoprotein A, and preferably I'm going to get a coronary artery CAT scan as well, the calcium score, before I would initiate systemic estrogen in a woman that's older than 60 or greater than 10 years postmenopausal. That is my uh action plan for them. And then and does she have a compelling reason to need it? And for me, the most compelling is osteoporosis. If she won't go on a bone drug, or she can't take whatever she's tried, she's not willing to try another one. To me, that's the most compelling scenario to initiate after that therapeutic window. But I want to dial in those, what is her risk for cardiovascular disease, and go a little extra mile about that.
We've talked a lot about the Prevent calculator, and I'm going to make sure we put the link to that in the show notes. It's from the American Heart Association. It's free for clinicians and patients to take a look at. So we'll make sure we give that to all of you guys that are listening. Well, Tori, how many hours do you think that you and I have spent in total talking about menopause and menopausal hormone therapy?
A pleasant amount.
Well, we get to add one more today. So, I mean,
I know we jumped right in there with some things, and we had a little technical glitches, and I was having a little hard time hearing. So I apologize for all that. But hopefully the spirited nature and goodwill nature of it all comes across and is helpful.
Definitely.
And a learning tool for folks.
I know there's more we could talk about too, because I think like even when we talked about testosterone or even testing menopausal hormone therapy, we've talked about that on prior podcasts, so I didn't bring that up today, but you and I take a little bit of different approaches on that, and I know we didn't even get into that hot topic today.
Yeah, I'm glad you didn't talk about that.
But I would just say if you are interested more in talking about that, we did talk about that in our last episodes. You can find that in the podcast history, and we'll make sure we drop that in there so you can hear the hot debate on that as well. But Dr. Hudson, you're a legend. Really grateful for you spending the time with me today on the Dutch podcast, and also just for your like continual commitment to women and to what I really appreciate most about you is you take a very straightforward approach to the recommendations that you make that's evidence-based. And I think with naturopathic doctors and like everything's trending, when you were describing these 3 eras of menopause, pre-WHI, the like extreme negativity of WHI, and then where we are now, I think about it as this like triangle. You've always kind of been in the middle where you have this very straightforward approach and are not subject to these kind of trends, which is really what medicine should be doing. So thank you so much.
Well, thank you for that.
There. Yeah.
I'll end with saying, because you brought that up, I'll end with saying, you know, I'm 74. I was born in 1952. So I've been thinking about menopause since November 24th, 1964 at 2 p.m.
Tell us more about that.
That was when my menstrual cycle started. And I was like, okay, when's menopause going to happen?
When will this end?
That's right. So I've been thinking about it for a long time.
Well, it shows. It shows because you bring a lot of expertise. So thank you so much. If
all right. I hope I didn't alarm or offend anybody, but
absolutely not. If people want to learn more about you, what are their best places to find you?
Well, I have a blog, Dr. Tori Hudson, and then the Institute, the postgraduate some virtual seminars. There are 4 seminars a year. And the big April menopause hormone boot camp happens every April. Our next seminar is in October, but we have different themes for each weekend. And our good friend, Dr. Jaclyn Smeaton, speaks at these on a regular basis. And but many incredible teachers. We just had one this last weekend. I learned something that was not on my radar, the glymphatic system. Dr. Deanna Minnick, you might bring her on. It's pretty fascinating, especially when it comes to this kind of cognition, brain aging stuff.
Yeah, that would be a great topic for us to cover.
So Institute of Women's Health, you can find the website.
Wonderful. Thanks again, Tori. And thank you all of you for listening today. And remember that we release a new episode every week. So if you want to join me every Tuesday, you can follow us. Subscribe at Dutch Test anywhere you're listening to the podcast today. And also be sure to follow us at Dutch Test on all of the social media platforms.
Incredible educational content you guys provide. Impressive. So thank you to Dutch for all the amazing speakers and education you guys do.
Thanks so much.
Thanks for joining us on the Dutch podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.